right. Show of hands. Where are the unjustifiably overconfident senior residents who are about to go out on their own? Yeah, you have a rude awakening, guys. All right, we're going to talk about what do you do when you're the only person and you've got a sick kid and you're not a children's hospital. If you look at the tertiary care centers, a couple things about them. One is they're geographically isolated. It doesn't mean they're not in big cities. They're all in big cities. But not most of the population is in the big city. There's lots of people out in the rest of the state that have kids that need their services. Community hospitals are locally based. So if you've got a really sick kid, you are going to go to the first big building that has a big red emergency sign outside of it and stop there with your kid. In the tertiary care center, all of the care is redundant. If you need a child that needs to be intubated, you've got generally a peds emergency physician, a peds emergency fellow, a anesthesiologist, a pediatric anesthesia fellow, a critical care doc, a couple of critical care fellows, some respiratory therapists. You've got about 12 people who can intubate this kid. If you're in the community hospital, it's you and you alone. The problem is that they really expect the same outcome whether you're in a community hospital or you're in a big tertiary care center. What's unique about it is, although you may have very talented people in the emergency department of a tertiary care center, the real problem is that the care in the emergency department is inversely proportional to the hospital's resources. So if you've got a ton of resources in the hospital, your emergency department care can just be, you know what, I'm going to watch this kid, I'm going to see how they do, I'm going to observe them. You don't have to be as good as a community doc in managing every aspect of the kid's care. That's not to say that they're not, they're outstanding. But you can get away with having that kind of attending who's a little bit resident dependent, not that we've ever seen any of them. But there are certain people that get really freaky if they have to work the shift during conference and always call one of the residents back to ask them a question and then have them hang around and help. So, all right. There is going to come a time, if you are in emergency medicine, where somebody's going to need a miracle, and the bottom line is you are their miracle. Now, part of the problem is when you're there by yourself, you have a limited ability to delegate. Okay, you have to do the critical thinking. You can't have somebody else focusing on a particular area. John, you manage the blood pressure. I'm going to go ahead and take care of the vascular access. Your procedures are 100% on you. Monitoring is 100% on you, and oversight's 100% on you. So it's not like you've got this really bad asthmatic, and you're just watching them. You're really worried about them, and you keep circling back and looking at them, and the nurses say, listen, Al, come over here. There's a really sick chest pain patient. So you grab, Gonzo, the tech, and you say, Gonzo, I want you to sit here beside this kid, and if he does anything, you come and get me. And you run, you take care of the chest pain. You come back from the chest pain, there's Gonzo sitting at the desk. I said, Gonzo, what the hell are you doing here? He said, Doc, that asthmatic, don't worry about him. He's sleeping like a baby, and his respiratory rate's 10. And it's like, okay, Gonzo, he didn't quite get the idea of a bad asthmatic, but okay. The key to it is you want to be able to provide the care from anywhere in the department, okay? So you want to minimize the multitasking. Get done what you have to get done on that patient so that you can move elsewhere in the department, because you're not just managing that patient, you're managing the entire department. Unlike at a big university center where you've got 5-6 residents who can manage the rest of the department while you and one other person can take care of the sick patient. So you want to quickly eliminate the things only you can do. Okay, so you're going to do the procedures that are necessary and the procedures that you anticipate. I think this kid's going to crump within the next 15 minutes. I'm getting the airway managed now, okay? By doing that, you maximize the number of clinicians you can count on. So if you've got a kid intubated, you've got the IV in place, you've got the drips running, you can go somewhere else and take care of something sick, and the nurses can come to you and say their pulse ox dropped, and you can say, okay, change the oxygen setting, increase the respiratory rate, do those types of things. So it facilitates your management options by you getting done what you have to get done, the things that only you can do as quickly as possible, and then that frees you up. Okay. When you are in the community hospital, observation is not an option. If Eileen and I were talking earlier, if you're in a center that's got a PICU and you've got a really bad kid with a respiratory problem, you can say, let's watch them. We're going to throw the kitchen sink at them, but we can watch them. They'll go upstairs. They'll continue to watch them. And then if they don't do well, they can do the intubation. You don't have that option. So your best guess is, I've seen these kids before. I know this one's not going to turn around. I'm going to intubate them early rather than later. So you're going to more or less anticipate the worst clinical scenario. The lower your confidence level in getting a procedure done, the earlier you want to attempt it. Okay, this is not like, you know what, I've got a bariatric patient that I need to do an LP on, but I think I'm going to order maybe another couple Sedrate and a procalcitonin and sign them out to the next shift type of thing. This is something where if you need to do it, get it done early, okay? It's not a time to be timid. Let's look at this. You've got somebody you're going to intubate, and this turns out to be the worst intubation ever, okay? So if you start your attempt here, okay, and it's god-awful. You're screaming, you're yelling, there's ET tubes on the floor, and, you know, everything is going on there. People from other stretchers have come over to help you out. And you finally get the tube in. You went from the kid with an O2 sat in the low 90s and a pH maybe about 7.3, and you get the tube in and their sats are in the 80s and their pH is 7.1, but you got it done. If you wait until that kid becomes absolutely moribund to start your attempt, and it's that same god-awful intubation, by the time the tube's in, you're now doing CPR on the kid. So give yourself a bigger margin of error. Start the procedures earlier rather than holding off on them. Okay? Be aggressive. All right? The other thing that happens is failed attempts allow you to engage your consultant further down the road. So if you try and intubate this kid and you go, all right, this kid cannot be intubated. They got some deformed anatomy, whatever. I'm putting an LMA in. Now when you get your consultants involved, they don't say, well, did you try intubating them? You know, what have you done for the airway? It's like, I've managed the airway, and this is where we are with it. Let's move on. Same thing for medical care. You want to be a little bit more aggressive. You have a kid who comes in with a seizure, you get the IV in, you're going to do send some diagnostic tests on them, a couple rounds of lorazepam, maybe check some blood tests, give them some Keppra, doesn't work, start them on ketamine, urine, you're getting ready to intubate them. When you engage your consultant, you got them down here, okay? If you don't do any of that and you're just kind of putzing around with the patient, waiting for a consultant to come back and tell you what to do, this is where you're engaging them. And they're going to tell you to do all the things that you, as an emergency physician, should have done to stabilize them. You're going to have to transfer the patient, obviously. They can't stay in your shop. So you're going to have to manage the consultants. And one of the things is be respectful from them. You can be nervous as hell, but don't yell at your consultant. They're going to help you out, hopefully. Okay? But more importantly, your actions, what you did to take care of that child up to this point, is going to define your capabilities. So if you can tell them, you know, exactly, I did this, and this, it tells them very clearly what it is they're dealing with. They don't want to hear about where you trained and how many articles you published and how many CME courses you went to. Getting them on the phone and saying, I went to Essentials 2017 will probably impress them somewhat, but it's not going to tell them what you can do. Joe Zaccardi told me once, he's the guy who started the residency program at Thomas Jefferson. He said whether it's peds or whatnot, in the middle of the night when you wake up a consultant, lead with a diagnosis. Don't start out with, I got Mr. Jones here, he's feeling a little bit down, his feet were a little swollen. It's like, I got Mr. Jones here with CHF. Boom, okay? So here's how you would present this kid. I have a 9-month-old male with septic shock. He's got diffuse purpur, he's intubated, I've got fluid resuscitate him, 60 cc's per kilo. He's on a 10 mic per kilogram dopamine drip. His pressure's 40/20. He's already gotten 200 per kilo of Rocephin, and we're going to start an epinephrine infusion. In 10 seconds, you said the following: I am a kick-ass good doctor. You can push me as hard as you want. I will respond appropriately. You're not dealing with somebody who you have to be afraid to tell them to do something. I can do whatever you tell me I need to do to save this kid. And I think your actions are so important when you describe that, because that more than anything is what's going to tell the consultant, this is what I have to deal with. All right, and this is exactly what Amal started out with. It's true, what you do matters, and when you're in the community hospital setting, it probably matters even a little bit more. All righty, thank you.